Welcome to the Department of Surgery Grand Rounds for September 2021. I think as you all noticed from the invite that you received for this event, unfortunately, due to the status of COVID, we are now back to a fully virtual meeting with not an in-person option at this point. Obviously, we'll keep you updated as things evolve. This morning, we have a fantastic presentation. Our speaker is Dr. Elina Quiroga, an associate professor in the Department of Vascular Surgery. I think she is certainly not a stranger to any of us. Dr. Quiroga started her medical career at the University of Buenos Aires in Argentina. She completed her MD degree there and then continued on to residency in Buenos Aires prior to coming to the United States as a fellow in Dr. Pellegrini's esophageal center. She then continued on through additional residency training here at the University of Washington and eventually a fellowship in vascular surgery. She joined our faculty in 2011 and has been with us since. Dr. Quiroga has a fantastic presentation for us this morning, and I think the background of the extensive work that she does in this area speaks for itself. She has done lots of local work for diversity, equity, and inclusion, being the co-director of our Department of Surgery Diversity Council, also being the director of the Carlos A. Pellegrini Diversity Sub-Internship that's been ongoing for greater than a decade. She is very active in the Society of Vascular Surgery and has done a lot of national work with diversity, equity, and inclusion in that role nationally. And is also, as we know, the Associate Program Director of our local Vascular Surgery Integrated Residency Program and Fellowship Program. So Dr. Quiroga, as we are looking toward another recruitment season this fall, this is an incredibly timely presentation. Thank you so much for being here this morning.
Thank you, Dr. Marquardt, for this warm introduction. I have no disclosures related to this topic. However, I want to give a huge thanks to the Vascular Surgery Division and the Diversity Council as a whole, as this presentation is a reflection of years of courageous work in this field. So why talking about surgical recruitment is important? We think every day we go to the hospital, we operate, we go to clinic, and we really think that we do our best for our patients, and we do. We treat everybody the same way, we have great protocols, we are great surgeons, we have a great team. But we're continually unearthing many examples of compromised patient care, biases, systemic racism that affect our patients' outcomes. And we have a long way ahead to fix this. But who is we? Who is going to find this problem and fix this problem? This is us, our teams, and the surgical leaders of today and the future. Who we recruit will shape the future of surgery. And our biases prevent us from seeing all forms of excellence. I choose these topics because we can't achieve our mission unless we have recruitment that can get all forms of excellence in across all perspectives and backgrounds, so we can improve the inequities in surgery. So how do we do that? With science help us mitigating some bias in recruitment. And let's talk about what are some of those problems. I think that several of you are familiar with this calculator. This is one example of bias medicine that I want to take a couple of minutes discussing. This is the American Heart Association risk score for heart failure. And basically, when you have a patient, the hospital gets compensated, it's considered a best practice to use this score. If a patient have a certain number, the recommendation is for the patient to be admitted to the cardiology service. If the number is low, the patient gets admitted to a regular floor under internal medicine or the hospitalist. And when you fill out a questionnaire, automatically, a patient being Black takes away 3 points. And that automatically made this patient less likely to be admitted in a cardiology floor. the authors of this very important paper, they have talked with the American Heart Associations, and there is, when you look at the data, they don't provide a rationale for this adjustment. But this rationale affects outcomes. In fact, there are multiple studies, but particularly one that look how implementing this protocol has measurable consequence. Black and Latino patients who go to an emergency room with heart failure are less likely to be admitted to the cardiology service, and they have worse outcomes. Another example is the Society of Thoracic Surgeons short-term risk calculator. This is a very complex score risk that look at risk of complications and death with the most common cardiac surgeries. You enter there more than 60 variables, and one of the variables is race and ethnicity. And the risk score for operative mortality and major complication increases up to 20% in some cases if a patient is identified as Black. If the patient gets identified as another non-white race or ethnicity, does not increase per se the risk score for death, but it increases your risk for major complications like renal failure, stroke, and prolonged ventilation. And this ended being a self-perpetuating circle. No, the patients are identified as worse outcomes, so they don't get offered the surgery that they deserve. And when asked about why race and ethnicity was included as one of the determinants of the risk, one of the variables, the authors acknowledge that the mechanism underlying this difference is not known. Again, perpetuating this circle of inequity. There are multiple examples in vascular surgery for absolutely every intervention that we made. Outcomes are worse for minority populations. And there is a study from California, I'm just going to mention very quickly, that the reason that I really like this study is because they look at the outcomes of endovascular procedure for peripheral vascular disease in all the patients in California, and they adjust for everything. They adjust for age, gender, comorbidities, insurance status, but also for the severity of the disease. Even after adjusting for everything, Black and Latino patients have worse outcomes and higher rate of amputations. And this study from the Journal of Vascular Surgery is one that is particularly telling for me, because this is an analysis of VQI, is the Vascular Quality Initiative, is like the database where we, our team here at Harvard University, enter their own patients. So these are our patients. And they look at multiple variables. The conclusion that Black patients have worse outcomes in every factor that they identify. But if you, for example, you look at open AAA repair for intact AAA no rupture, Black patients getting an open AAA repair were significantly less likely than white patients to get an epidural. That's considered best practice in this case. And they're also less likely to be extubated in the OR. That's already a complication, maybe because they're in pain, maybe because they didn't get an epidural. And after that, they have worse outcomes, almost expectable. But this doesn't happen to others. These are my patients. I put data onto this algorithm. So I need to look to see if I am treating all my patients equally. These are very specific examples, and I actually have a very hard time choosing which ones to share because there are so many examples of biased medicine. If you have time to read one paper, I put a QR code. You can download this paper from the New England Journal of Medicine called a Hidden in Plain Sight. I am sure that you're going to find one example of biased medicines in something that you may be doing day to day. The list of biased medicine protocols and guidelines will get bigger. And the science shows that epidemics, disasters, climate crises are and will disproportionately affect marginalized populations. So how do we build surgery teams that can identify and tackle these problems? So let's look at an example of how diverse perspective in a team have an impact in reducing these inequities. And this is a complete bias, talking about bias, complete bias example of this. This is my team. On the top picture, you can see my current residents and fellows, and I am very proud of each one of them. But also, I want you to take a couple of minutes to look at the map and look at our graduates, our recent graduates from our program. We have graduated an excellent and outstanding cohort of vascular surgeons. They're making a huge impact in our community, filling needs in health equity. For example, we have 2 of our recent graduates that have gone to practice in Alaska, one of the most underserved populations in the country. We have 1 recent graduate that went to work in Montana, in rural surgery in Montana. 30% of our trainees are now in academic jobs, University of Rochester, Maryland, and VA in Philadelphia, doing amazing work in research and education, shaping the future of vascular surgery. We have 2 of our trainees doing complex aortic surgery in the Rockies in Denver. And about our future graduates, I have 3 trainees that are hopefully going to graduate in July. 1 is looking to going back to Tennessee, going back to the South, helping the population, helping his community reduce the risk of amputations, a problem that impacts Black patients disproportionately, hopefully getting a job in Memphis. Another of my trainees is looking for a job, maybe in Spokane, maybe Montana, also going back to serve our community. And another one is looking for an academic job. In sum, this is an incredible diverse group of vascular surgeons that are going back to work in our community and in academic jobs. And this is not bragging, maybe just a little, but this is showing the impact of our program in vascular care across the country. So what sort of work we can do to keep growing this impact? And it all starts with recruiting. Which gets us to the core of this presentation. What are the steps that we can take to mitigate biases in recruitment so we can achieve a team that is diverse and excellent? So I see like 3 big opportunities to work in these topics. One is when all the applicants apply to our programs. And today is September 1st, so the medical students in the room have the opportunity to submit all their applications to ERAS. And from there, we decide who do we want to meet, who is the person that we really want to meet, and we think after looking at the paper application that that's a person that will be a great addition to our team. When we do the interviews, one of the things that we look is bringing this resident to our programs. We help that resident reach their full potential. Are we the best place for this medical student? And also, how much this resident will help grow our team and help our team get better. And lastly, during the confection of the ranking list, how we prioritize, who we choose between the students that we interview, which ones we really want to join us. So for the application part, reviewing the whole pool of application is a huge honor and a big responsibility. This should not be seen as a task or a tax for somebody in education. This should be as what it really is. The team that is in charge of the first pass have the access to the whole pool of applicants, have the potential to look and tap and find those special traits in an applicant that you said, I want this person to be part of my team. We do an holistic review in vascular surgery, although we don't do absolutely everything that I'm going to talk, we don't have implemented all the best practice, we do several of these. So what are some of these actionable steps that we take when we are reviewing the applications? So one of the first things that we do, because we know the bias in the applications, when our program admin downloads the applications, we don't get a picture. We never look at the picture of an applicant when we're reviewing the applications. And I think that you're all aware of the data from the orchestras, for example, when the musicians switch to audition in front of the conductor and the selection committee and the audition behind a closed curtain, the outcomes completely change. Not only the orchestras become more diverse, it also the performance got better. And there is a lot of similar data from the business world, and also there is a fascinating paper from radiology that I'm going to discuss. So do you think that a resident should use more money in books or instead invest on Botox or a good Photoshop work for eras. Unfortunately, the data shows that you are better off using your money in Botox or in facial appearance. So they did this amazing study that they basically recreate a whole era's website. They got 5 institutions to have several faculty looking at the same way they were thinking they were reviewing applicants for the interview. They didn't know that there was deception was being used. So they have a picture and they have 2 big groups of pictures that were selected as being facial attractive and some that were chosen to not be attractive. They also look at obesity and several other factors, but the most important was how attractive the picture of the person was in the picture from eras. And unfortunately, the facial attractiveness of an applicant photograph was more influential than the preliminary class rank, the clinical clerkships, honor society memberships, number of publications. All that has less weight in getting an interview than having a good, nice picture. And in fact, when they look at the numbers, having a good picture change your step score approximately 10%, increase your step score approximately 10 points. That's quite significant. And talking about honor societies have their own biases. And in the last few years, a lot of attention has been brought to AOA, for example, induction. So they have looked at several research studies that have looked at AOA status within a whole pool of resident applicants. And they have adjusted for multiple things, including the numbers of volunteer work, leadership positions, research, the grades that they got in the clerkship. Even after adjusting for everything, white students have 6 times more chances of being inducted as AOA than Black applicants. So what do I think? Should we bias, should we blind ourselves also to all this data? No, we should keep it. We need to have it in the application. And it has value being an honor society. We just need to be aware of the bias that this can introduce in the application. And another topic where there is a lot of research is in letters of recommendations. We all love to read into letter of recommendation. We like to find one of our friends or another faculty for another institution that we really respect and find out what that person wrote about that applicant. However, we need to be aware that there is a lot of bias. There's a whole body of literature that have looked at gender bias and letter of recommendations. When we write a letter of recommendation for a woman, they're usually shorter than the letter of recommendation for a male. They have 2.5 less chances of mention endorsement. They will mention things like, she can do the job versus she's the best person for this job. They talk more about the effort and less about the actual result. She is hardworking and dependable versus skilled or accomplished. They forget to use the doctor or the different title that the person may have. And even more important, they are 7 times more likely to include details about personal life when the person that the applicant is a woman versus a male. And this is true regardless of who writes the letter of recommendation. It has the gender is a male or a female writing the letter of recommendation. I personally really like this one page from the University of Arizona, and anytime I need to write a letter of recommendation, I put that in one side of my monitor and I check myself. And if I have to write multiples, I try to do it all at the same time and I compare just to check my biases, because we are all going to be affected when we write this letter of recommendations. So we talk, and we have now narrowed the pool of applicants from, in vascular searches, usually 120 applicants, to those that we want to interview, the people that we send an invitation to come and interview with us. We already think that each one of them has the potential to be great residents. So the interviews are critical at this moment, and the biases affect the whole interview process. But there are different biases that are going to impact, especially now with virtual interviews. So the WAMC have provided guidelines on what are the best practice for interviews, and there is also a lot of research done on this focus. But one of the key things that we suggest is that you focus in the interview itself, in the moment that you interviewing that person, not in the criteria of academic metrics, because when you review the application, the group that reviewed the application already took care of that problem. They already look at the scores, they already look at the grades. Now we're looking at the interview, the interaction itself. Just remind yourself that biases exist before each interview and before each decision that you're taking when you're rating an applicant. And one important tool to mitigate bias is just reminding ourselves just before having an interaction or taking a decision that we have them, and make some quick exercises to surface your own biases. Dr. Quinscaper has done a lot of research and has published a lot in how to address bias, especially in the applications to medical school, in the admissions to medical schools. I particularly like this approach. They have like 4 steps that you can take and when you're interviewing somebody. And one of the ones that I really like to do, and it takes literally a couple of seconds, is called consider the opposite. So you finish an interview. In the moment that you finish, you're ready to score that applicant. And after getting that kind of initial initial impression, take a mental pause to re-review the data, to re-review your interaction, and try to look for evidence supporting the opposite conclusion. For example, if you really like that applicant, try to look for 1 second what other people will not like. And the opposite, if you didn't like somebody, try to put yourself in the role of somebody that really liked that person. And what are the attributes that that person can bring to your team? And this is followed by making a final decision, but just take 1 second to pause and reflect and consider the opposite of that interaction to see if that changes how you see that person. They also talk about trying to do a common identity formation. Remember, we all want to be good surgeons. We all want to do the best for our patients, and do some counter stereotypical exemplars and the perspective taking that are a little more complex when we're doing small, short interviews. What are the recommendations? One of the main recommendations, and that came from the emergency medicine literature, is to do multiple mini interviews. The interviews need to be short. The AMC says that all interviews should be short, less than half an hour for sure, ideally less than 15 minutes. And what they recommend is the applicant meeting with multiple group of people just for 8 to 12 minutes. In vascular surgery, we do sometimes 12 minutes, sometimes 15, but never more than 15, and they're always based on similar traits. We recommend that you use structured questions. These are mostly behavioral questions where these are the major predictors of success in a job from the literature in business, but also from the literature in medicine, decrease the chances of attrition. Asking medical student situations, for example, challenges that you have faced and how they handle, like typically is about conflict resolution. How do you deal with somebody that was underperforming when you were in a group? And mostly used for fellowship, structured clinical scenarios, just pausing the applicants, presenting a clinical scenario that is already structured and see how the applicant goes through the steps and reaches a decision. The Diversity Council have created a set of questions that you can all use to interviews. These are not just for residency or fellowship, they can also be used for faculty recruitment. And those questions has actually a double goal. For one side, they help you evaluate how the applicant's values, diversity, equity, and inclusion work. Now, is this applicant really going to be aligned with our mission to improve healthcare inequities in surgery, but also signals the applicant our commitment to address healthcare inequities, our commitment to this work. We're talking about these issues on the open. We're in an interview and we're asking an applicant how they think does systemic racism affect outcomes in surgery. This is the Department of Surgery priority. If you came here, we're going to be talking about these topics. So it helps in both ways, not us just telling the applicant what we think, what we are evaluating him or her. It also helps the applicants knowing what's our posture. And I don't know if Dr. Sarah Kim is on the call, but there's a paper that came here from Dr. Stephenson Fahmy. They did a huge literature review of all the data about surgery residency interview. And they also recommend multiple interviewers, and that's something that having a short interview allows you to have at least 2 people interviewing at each time. So you have one observing and one asking the questions at all time. Ideally, 3 people in the panel will be better. And there should be some kind of training for the interviewers in the scoring format. It should be like some kind of agreement before. And lastly, there have to be a code of conduct, agreement of what kind of question we're going to ask, what questions, and we need to ensure that everybody that's interviewing knows what questions are illegal, what questions are forbidden by the match. And the match have done, it's very clear, there are things that we cannot ask an applicant. We cannot ask about race, religion, we cannot ask about family planning. Yet, they recently have done a study, and they did a similar one in vascular surgery this year. It was presented a couple of weeks ago, but have not been fully published, where 74% of applicants reported at least one illegal question being asked during the application cycle. The applicants in this survey, they said that just being asked about an illegal question will put that program lower on the rank list. And also, the most common asked questions was family planning, especially for women applying, and this is just specifically for surgical specialties, and was very marked in the orthopedic world. So things to be aware about these questions, a code of conduct, and we all agree, everybody that's interviewing agree that we're not going to ask about this. I'm just talking a few more seconds about instance biases. It takes literally a microsecond for us to make an assumption about somebody. Is this person, are we going to trust this person? This person looks competent. And even that we don't think, we already make that impression. Having a quick interview chit chat, like running into somebody when getting the coffee, when we used to do breakfast. And if there is any point of contact, like you find, oh, they use my same laptop, or they have my same code, even the small things, that candidate, even if you don't realize, is scoring some points on you, and you're automatically biased in favor to that person. Even more important this year and last year, technology. Technology plays a huge role. There's a lot of things that we cannot evaluate when we're having this kind of conversation. It's so difficult for me to giving this talk. I don't know if everybody's sleeping at home or what's going on, but don't having the kind of two-way feedback. But particularly for technology in interviews, just remember that subtle connectivity differences, having the video resolution that's not good, a delay, the way that when you speak, the sound comes later, and this mismatch between your sound and the visual. The background, everything is going to change your perception of how intelligent or how smart this person is. And you need to be aware that not everybody will have the best connection. Not everybody will be able to have a rate my room, perfect 10 over 10 room. But those are things that are going to impact your first initial impression when you meet the applicant in Zoom. And finally, similarity. We all gravitate and trust people that look similar to us. That's the way that we are. But remember that the goal of the interview is not find a lot of people that look like you. The main of your interview is to help create your residency program in a way that aligns with the mission of your program or the department. So we talk a little of the applications and the interviews. And lastly is the moment of the rank list. And that's one of the most crucial moments for a program director. They have narrowed from the hundreds of applications to the people that they interview, and now they need to make a rank, hoping that the applicants, there will be some concordance. So when you're making the rank list for all those people in power that have that chance, just remind yourself of all the bias that play a role in every step of the application process, and go back to what's the mission, what's your goal, what do you want for your program, how do you want the future leader in surgery to look like. There is a push, especially for the AMC and many other institutions, about limiting post-interview communication, reaching out to residents, to applicants, and even the applicants getting back to us. It has not been completely forbidden, but we know that the communication should be limited, and we should never ask for an applicant to reach out to us specifically. We should answer any further questions that we have, ideally in an open format, like now that we can do it via Zoom, to have a get-together moment and another open house before they submit the rank list, just to clarify any question that they might have, but don't have the expectation that the applicant needs to reach out to you, and that will determine your position in the rank. Second look interviews are another big source of bias. Before COVID, this was very frequent, and some applicants were requested to do a second visit, a second look. And second looks interviews are known to introduce a lot of bias, to the point that several institutions have asked for this to don't be allowed. This year, with the presence of virtual interviews, some institutions across the countries are organizing, it's not really a second look, but they're organizing like a tour for the campus with the premise that the main team, like for example, somebody's applying to Vascular, after we finish the interview period, the GME of that institution holds a second look or get to know us in the campus, where the applicants get a tour of the place. They get to interact with some people, not for the program, from other sources, like for example, from different programs, but not the applicant's program. And the program director cannot be informed, cannot know which one of the applicants participated on the tour or not, to decrease bias. And just remember that doing a second look requires a lot of money and time, and actually self-select the group of people that are going to be able to come for a visit. And last but not least, all this is going to change in the near future. Some programs are moving towards signaling, and I don't know how familiar you are about signaling, but it's a very complex procedure. And what started this was ENT, and now also urology is moving towards signaling, where basically after ERAs open, but before the interviews are granted, it's in the, this year is before September 25th, the applicants can choose 5 programs that they are really interested on, and let those programs know that they're really interested on. And the same thing with the programs. It's like a pre-match. Looked like in ENT, applicants were applying to more than 70 programs. It was a little out of control how competitive it was. I don't know exactly how signaling is going to play off. I know the vascular surgery is not moving this year or next year. We're not going to start signaling yet. But some programs in general surgery are going to do a pilot program of signaling this year. I don't know how it's going to work, but I'm sure that's going to introduce new biases. And I hope there's a lot of literature that comes that tell us how we can better deal with signaling, as it will reduce the pool of applicants to a group that have already tell us that they want to be here. So we have looked at many practices that can mitigate bias in recruitment. These are important because they're critical to get our vision of a future where health inequities are addressed. If we want to achieve that vision of health equity, We must have the courage to change everyday practices. I know it feels very unusual to interview somebody without knowing all the data, without knowing the step scores. By the way, step one, this may be the last year that you're going to see an applicant with step one scores. After 2022, they're going to be pass or fail rates. So we will not have that piece of information. And change requires courage, and that we go outside our comfort zone. The Diversity Council has a representative on each division and each program. We can help you. We're here to support positive, meaningful change. We have the tools to help you success with Recruitment for Excellence. We can have a deeper discussion of the literature and clarify your doubts. Ask for our advice and reach out. Thank you so much for your attention. I hope that this presentation can generate some discussion. I'm happy to answer any questions. I'm way more faster than I should, so I finished a little early. Dr. Wood.
Thank you, Dr. Wood.
Dr. Quiroga, that was so informative. You know, my first comment is, of course, I'm aware of a lot of what you talked about, but you organized it and brought forward so much stuff that I was riveted like I haven't been for a grand round. So that's nothing against any of our other grand rounds. It was just, I think, really rich in information and practical points on how we can be better. I want to ask a question on the signaling that you just talked about, because I think one of the concerns, particularly with virtual interviews, is the ability for candidates to really have unlimited programs that they apply to. And a feeling last year that there was a cohort of top students that that may have unintentionally made it more difficult for middle tier students to be competitive for interviews at programs. And I think this is a driver for signaling to try to limit how many programs a student can express high interest in, and it with its goal in improving equity. But I can also understand that it could have the opposite impact. So say a little bit more about signaling and what your advice is for us going forward. And we have 4 programs, and you know, all of our 4 programs are highly competitive. And whether this is something, when I'm looking at it at the college level, that we support or don't.
Thank you. Signal is a very complex topic, but interview application, I think that it went out of control, and especially with removing the barrier of traveling. Last year, as people may be aware, there were some programs that have 20% of no-shows for the interview dates. So people that have signed up for application for interviews, and the day before they will cancel or they will not show up directly for interviews, damaging all that middle group that didn't got the interview because that person took all the spots. I think that there is a role in signaling, and I think that we're all going to move for signaling in the future. I mean, an applicant applying to 60 spots, and like that's what happened in ENT, that's the mean. Like people that came from very good institutions are applying to 60 to 70 spots. That's out of control. How we're going to work in getting those 5 or 10, or how many tokens people should get, I'm talking about programs and I'm talking about residents, I think that that's going to be the difficult discussion to have. But having some kind of pre-agreement about these are my top choices, and the same thing from the programs, it may help. My guess is in 3-5 years, most of the program will have moved to signaling, or some kind of restriction in the number of applications are going to come. especially when you take also step 1 out of the picture. That's another big topic. I purposefully didn't dig that much on what I think about scoring, but taking step 1 out of the equation for applicants is going to change a little how programs evaluate a resident. I personally think that's a good move to go to a pass and fail system, but I understand why some people are scared about this movement. I'm looking forward to the data from this year for signaling. Last year was very limited, and on top of that, we have COVID as the first year that we're doing everything virtual. But my impression is we need to start looking more seriously about signaling because it's going to be the next step into interviews.
Well, you just brought up my second question. I'm going to not dominate. I will let other people ask a question, but should we eliminate looking at the step scores altogether?
Yes, that would be the short answer. There is one caveat for that. And so for people in the audience, we know that for some reason that people cannot completely understand, but mostly the way that students are raised since kindergarten about answering tests, why males score well in a standardized test compared to every other group. So any standardized test that you take since high school is biased on the results. And step 1 has a very, very high rate, pass rate already. So it's not a problem about who passed or who doesn't pass. One of the groups that most probably will get more, I don't know how to use, may not win for taking this out is actually international medical graduates. And that's why I want to mention as being, I am a complete outlier. I'm an international medical graduate, but I have horrible step scores. But the truth is that for most international medical graduates, a way to differentiate was to achieve an incredibly high step score. And those are the ones that we may lose. And there is a lot of talent. I'm not talking about me, but other people that we all know that are in the school about international medical graduates that we should keep looking. Most applicants are not going to take a step 2. If I was a medical student, I will not take a step 2, but people are going to give a high weight to that steps 2 score because we still need some reassurance from the numbers. The way that we have always take decision is based on numeric data.
So we'll have a question from Dr. Dick, and then I have a couple from chat.
Hi, Elena. Great presentation. Sort of back to Dr. Wood's question, I think what we need to do is sort of change our mindset. We're sort of in this fixed mindset of what excellence looks like. And I think that's actually a change of what it means to be excellent. And, there's a Harvard Business Review article that came out that says, why does diverse teams matter? And this was in 2016. And they mentioned a whole bunch of things, different perspective, increased creativity, increased profits, improve hiring results, so on and so forth. And, so the business world has kind of got it. And I think from a healthcare standpoint, we have to figure out, we're kind of behind the 8 ball of how we think what excellence looks like. And we also have to think about who are we serving? We're serving, this population of patients that without having sort of workforce diversification, you're never going to have excellent patient outcomes. And the data suggests that, having a diverse workforce, it increases physician-patient concordance, it mitigates disparate care, improves outcomes, you have higher patient satisfaction. And again, our population is continually becoming more diverse. So as we sit down and we try to decide, as we're trying to pick who's going to be the next sort of leaders in surgery, in academic medicine, clearly, you have to think about sort of workforce diversification. That's sort of very critical, and sort of to focus on, okay, a person has, 300, whatever the step score is. You also got to think about, the person who comes in with a lower score, what is their lived experience to get to that point? You know, these are the intangibles that people don't necessarily think about, that you know, people, not because you don't have a high board score doesn't mean you're not going to be a good physician or a good candidate. And I could say, like Elina, you know, I didn't have 250 on the board scores, but today I'm sitting here talking to you as the surgical director for a kidney transplant program that's one of the best in the country, with great outcomes, and the interim surgeon in chief. And, you know, by all sort of means, you know, if I was coming into this, people would say, hey, you know what, you don't qualify because you didn't have a high board scores. So I think we have to move away from this fixed mindset of what sort of excellence looks like. Because if you continue down that path, you're going to continue to pick the same people, and we're going to continue to have sort of disparate outcomes. Again, I'm not saying that you should sort of penalize people for being, you know, having good grades and all this other stuff, but sort of look at a more holistic perspective as when you're picking, and it's instead of sorting talent, which is what we're doing right now, you know, we should try to think about how do we grow talent. And so I don't want to ramble, but I want to give other people opportunities. But I think that's an excellent presentation, Elina, and I'm happy you're here and all the great work that you're doing.
Thank you, Andre. And you bring an important point, is what this pool of applicants that we get the application for. There is something that I didn't talk. It's about the pipeline, no? And how the numbers of minorities and graduating from medicine is not increasing, have not increased at all. In fact, Black men in medicine graduating are decreasing in the last few years. So I am very proud of the work that other people in the call are doing, trying to increase the pipeline from high school to middle school to undergrad. Every one of you, the mentor and undergrad applicants, I am very grateful, because that gives us the possibility in the future to have an applicant in the pool that we can grow to be a leader in the future.
There's actually two questions I'll combine from Dr. Roger Tatum and Dr. Teresa Kim. They both had questions along the lines of, you know, the fantastic information presented this morning. You mentioned a list of questions from the Diversity Council, but what options are there perhaps for either workshops or existing resources that our local Department of Surgery Diversity Council could provide as we are facing the next interview season?
So one of the first things that we did, and I cannot thank Dr. Marquardt enough, last year when we moved to virtual interviews, we talked about getting some time to talk about implicit bias and how they affect the application cycle. And when this opportunity to do these grand rounds came recently with a change of speakers, Dr. Marquardt remembered and give us this space, because it's almost unheard to have this space of the whole department coming together and doing the first talk about how implicit bias affect outcomes. There is a lot of resources that we can share. Most of the work is actually not done by us, but Dr. Sarah Kim, that's one of the members, and Janice, I cannot remember the last name of Janice, Sabin, Dr. Sabin also have produced a lot of materials. For example, that 4 techniques that you can use for mitigating bias. There is a very cool, it's like almost like a TikTok. It's like a 90 seconds video that you can watch and helps you understand biases. And help you actually not understand, surface your own bias, and gives you a very quick reminder. I'll be happy to discuss this, and we are presenting, we're adding to the agenda of the next educational meeting in 2 weeks, and the topic of these questions. And we're also going to meet with the division chief of each program. So when they're recruiting somebody, they know we implemented these standardized questions, and now we have grown this pool of questions. When we did the recent trauma surgeon search that was led by Dr. Bolger. And that was one of the first moments that we said, yes, we need to keep growing. We need to keep including these metrics when we recruit somebody at every step of the department, maybe including the staff.
There's 2 questions from Dr. Shaloub. The first is, please comment and explain what the impact of minority tax is that occurs in the creation of a more equitable world. And secondly, how do we handle the backlash associated with this work that she said that we have seen in vascular surgery on discussion boards as well as in general surgery, the cancel culture?
Okay, easy question, Dr. Shalhoub. A couple of things. First, I'm going to address the how do we address the backlash? And this is a society that we live, and thinking that we are in a bubble, that surgery is not affected by racism, that racism doesn't exist in medicine, is a problem. I mean, that's not true. We are part of the society. We are not immune. And in our department, we have really surprising answers to the survey that we provide and comments being made. And the same thing in vascular surgery. Recently, there was a lot of backlash. We did a survey at the Western Vascular Society, and some of the responses were surprisingly. Basically, you keep doing your work. You keep trying to educate people and hope that people will eventually understand what's going on. I don't even know how to explain, but the fact that we all agree that this problem exists and it has to be acknowledged. There are people that will make comments and will disagree. There are more probably people right now listening to this talk that thinks that meritocracy exists in a vacuum and there is no power that makes you change that. And talking about going outside meritocracy and looking at a holistic approach is wrong. I am sure there must be one of you there. And I wish at least one of the concepts that we talked today make you think about another option, that you can consider the opposite and see how other people see this issue. And the first question about the minority tax, the way that I see minority tax is somebody have to do the job and you need to find your priorities. For my residents and fellows, I let them lean in diversity work as much or as little as they want. And I try to be very respectful of how important it is. For some people, this is what brings you energy. This is what what gives you fulfillment after taking care of your patients. Being able to talk, being able to meet with an 100% minority student that's applying to surgery, it may give me more energy than having a paper accepted to a place or something like that. So minority tax exists, and we are very lucky, although not lucky, it's a reflection of years of work. The Department of Surgery recognizes work. So it is a tax, or it was a tax, but now we recognize this work. When somebody in our goes up for promotion, work in diversity gets counted because we know the time that gets, the effort that requires, and that gets counted as a scholarship activity. That's something that you are doing to make this a better place. We were the first program in the first department in the whole School of Medicine to change our code for appointment and promotions. And in fact, now it's part of the whole School of Medicine promotion code as well, because it was a tax, but we are working more and more to recognize formally diversity work as an academic scholarship activity.
There's another question from Dr. Estelle Williams. She said, can you address the idea of culture and fit for a program that is sometimes used as coded language when we try to move away from objective data like scores?
Yeah, I managed to do my whole presentation never using the word fit. And people that knows me knows how much I dislike the word fit. And I really don't understand what when we talk about fit is a code word for, is this person like me? It's like person going to be the same kind of people. And that's not what we look. What we look when we're talking about excellence is people that are different, people that challenge your ideas, but they have a shared goal, that they share the mission. For example, if the mission is to provide the best compassionate care to every patient, that's one of the mission of the Department of Surgery, looking for that person. but not somebody that fit, not somebody that looks like you. And I will actually be very careful about using the word like, oh, people came here to settle, they couldn't interact with us, so they don't know if they will fit in our program, what exactly fit means, and try to avoid this word because they actually take us away from what we are trying to achieve, that is excellence.
I think we have maybe just another minute, and then we have a short announcement at the end. I want to give the opportunity for anyone to ask another question or continue with the discussion. All right. Well, Dr. Quiroga, thank you so much for presenting today. I think this is beyond important. It's really critical to the future of our Department of Medicine and how we care for patients. So thank you again today for presenting. I think Dr. Catherine Benny has a short announcement for us all.
Hi, good morning, everyone. I'm just going to share my screen here if I can. Hi, so I'm Dr. Catherine Benny. I'm one of the clinical R3s here, and I just wanted to take 5 minutes of your time to talk about an exciting opportunity from the Department of Mechanical Engineering. For some of you who are in QA/QI here at Montlake last week, I've already talked with you a little bit about this. So each year, the Department of Mechanical Engineering runs something called the Engineering Innovations in Health Program. And this is a clinician-driven program that combines multidisciplinary teams with engineers and clinicians in order to address your unmet healthcare needs. Really, EIH follows a needs-based design philosophy that starts with your unmet healthcare need and examines stakeholders, market opportunity, intellectual property, FDA regulations, and reimbursement considerations as we try to create a solution for your need. Each year, clinicians such as yourselves are invited to pitch your clinical problems to a team of engineering faculty, and projects are selected and paired with an engineering student team to create some innovative new solutions. The initial part of the program in the first quarter, the fall quarter, is focused on brainstorming and needs analysis. And then prototyping and testing starts in the winter quarter and continues on towards the spring quarter. Many projects live on beyond this one academic year program and go on to participate in health innovation challenges, startup competitions, and several have actually spun off into their own companies. The project team really consists of a student team from multiple different engineering disciplines, including both undergraduate students and master's students. The clinical team, it can be physicians and nurses, nurse practitioners, and then the teaching team, which consists of engineering and business faculty, as well as experts in regulatory, intellectual property, business, and design and manufacturing. So just to give an example, this is the broad array of the team that they actually have. Many students and projects have gone on through EIH, and currently we have over 15 provisional patents and 9 projects that are currently in early stage commercialization. So really what I would like to do, and the Department of Mechanical Engineering would like to do specifically for surgery, is we want to invite you to submit your unmet clinical needs. It takes about 30 minutes to an hour to complete an application in total. And after the application, you'll have a chance to do a 10-minute pitch to the faculty team. And then if your project is selected, you'll go on to work with the engineering team about 1 to 3 hours a week as your time commitment. Just to give some examples of the broad array of different projects that they've worked on, here is a specific laryngeal airway mask that was designed for safe neonatal intubation, rapid and safe neonatal intubation. And this has gone on as a spin-off company through CoMotion here at UW. We have also worked on projects for IV fluid regulation in low-income countries for neonates. And some other ends of the spectrum, affordable epinephrine auto-injector, in which the auto-injector is retained and the epinephrine cartridge can be exchanged. So if you expire your epinephrine, you can replace it with a new one. I personally have also run through the program with 2 different projects. One was an attempt to create a better and automated incentive spirometer that would automatically collect PIC scores. And the other is working on a new monitor to identify capillary permeability in critically ill trauma and post-surgical patients to to improve IV fluid regulation management. So really, again, please, if you have a pain point, something that's driving you insane, whether it's the, if patients aren't using their incentive spirometer, the OR lights aren't functioning well, your patient's IV pole is beeping all night and you want to have it as a Bluetooth connectivity to the nursing station, if you want to have a better self-retaining endoluminal stents, whatever it may be, if you have a problem that you think there could be a potential engineering solution for it, please, I really encourage you to take about 30 minutes to put together your need and submit your application. They are super excited to partner with surgery this year and have extended their deadline through to the middle of September in order to recruit more surgical applications. And then this is roughly what, again, what I've talked to you about how you apply and what the time commitment is. And I'm happy to take any questions. Thank you for your time.
Dr. Benny, if there is someone who has an idea, is it possible to reach out to you just to sort of get those links and direction to move forward?
Yes, absolutely. Thank you for bringing that up. If you have any questions, you think this is, you have an idea, you have an inkling of it, please feel free to email me directly. I'm in close contact with the director of this program. I'd be more than happy to either to send you the application or to put you in contact with them to get more information.
Fantastic. Thanks for presenting this morning.
Thanks so much for your time.
One final comment, Dr. Quiroga in chat has put a link for our local Diversity Council website and some resources that they have. So as a follow-on from this morning's presentation, please take note of that before this session closes for those resources. Thanks, everyone. Have a great rest of your day.